So colloids are protein substances that increase that colloid oncotic pressure and moves fluid from the interstitial compartment into the plasma compartment by pulling fluids into the blood vessels. So here's a picture of your blood vessel, and you can see your proteins are these large particles, and they help keep fluid in that vascular space. So that is what your oncotic pressure is keeping that fluid up. If your protein goes down, then the fluid leaves your vascular space and ends up in your interstitial space. So the normal three blood proteins are albumin, globulins, and fibrinogen. And so the one that we're most interested in is the protein called albumin. And they also could be dextran, so a carbohydrate or a starch. There's also fats, which are lipid emulsions that are administered for patients that are on total parenteral nutrition. And there is gelatin would be considered a protein as well, not that we inject that into a vascular space, but the albumin is a natural protein, and it's normally produced in the liver. And when we have liver damage, we see a drop in that albumin, which causes a drop in that colloid oncotic pressure. So dextran is a solution of glucose. It's available in two concentrations. There's a 40 or a 70% solutions, and they have a molecule weight similar to that of albumin, so that it helps expand the plasma volume by drawing fluid from the interstitial space into that intervascular space. And that would be used to help raise a blood pressure or to shift fluids. So someone with that's had high IV volume, to bring up their blood pressure during shock, we need to shift fluid out of the interstitial space back into the vessels so that it can circulate. Then we would use one of these colloids, so your albumin, which comes in two different strengths, so your 5% and your 25%. They're from human donors, and then your dextran and head of starch are two other commercially prepared proteins that increase your oncotic pressure. So blood products are from donated people to use as a replacement for patients that may be missing some of those cells. So for packed red blood cells, it is exactly that. It's red blood cells that's had some of the plasma removed to make it packed red blood cells. So it's used for someone that's had an acute blood loss or has an anemia. And generally speaking, 1 unit of packed red blood cells will raise a hemoglobin by 10 grams per liter. So red blood cells contain oxygen carrying capacity. And so for patients that are needing an increase in their red blood cells because they are anemic, then we would use a packed red blood cell. Blood products are more expensive than crystalloids or colloids, and they're less available because they need donors in order to keep that blood supply up. We would choose a packed red blood cell for a patient that has lost, say, 25% of their blood volume. So it could be used for someone that has had a intraoperative bleed, or with a surgery, or some sort of a hemorrhage. And let's see, they pack the cells by using a centrifuge, so it separates the red blood cells from the plasma and the other cellular elements. The advantage of using a packed red blood cell is that we can give them the oxygen carrying capacity of a cell without the fluid overload that could cause some cardiac problems. There is a platelet product and that would be used for patients that have a thrombocytopenia. So anyone with a low platelets, they may be offered a if they had thrombocytopenia, they may be offered platelets. In the case of someone who is bleeding, say related to an overdose of an anticoagulant or those types of things, they would use a fresh frozen plasma instead of platelets, because the fresh frozen plasma has other clotting factors to help control someone's bleeding. They would also use fresh frozen plasma in the case of hemophiliacs, if they were to come in with a bleed and their specific factor was not available. We'll talk more about hemophilia in term 6 and each of the factors that can be replaced. Albumin, we've talked a little bit about. That would be offered in the case of a hypovolemia or a hypoalbuminemia, so someone in liver failure that can't produce their own albumin would be offered albumin, or in that case of shock where a crystalloid isn't the best option. And then cryoprecipitate is to manage acute bleeding, and that is something a hemophiliac would be offered as well, specific to the factor that they are missing. So the contraindications for blood products are they're there, it's around your immune system. So that's why blood products need to be cross-matched to your donor to your type, to make sure that you don't have an immune reaction that causes the body to destruct or destroy the blood cells. But in the case of someone who needs a blood product, then the risk is outweighed by using an Rh negative type product, so that the immune system doesn't attack it. So we do want to make sure that it is compatible with the recipient's immune system. So they do a cross-match and testing to monitor the type of blood to make sure that it's the safest for that patient. And then the things that we need to watch for when we are giving a blood product is that we watch for transfusion reactions, any type of anaphylaxis. There's always a risk of transmission of pathogens. We've come a long way in knowing what pathogens can be spread through blood products, and in that case we are monitoring for those, but we're only at the mercy of what we know. So I remember working as a nurse before we knew what hepatitis C was, and of course we were giving blood products to patients, and we did give them hepatitis C because we didn't know that virus existed, and so there was no test for it at that time. A consent needs to be signed for a patient that's getting a blood product, so an agency will have a protocol around a consent to make sure that the patient knows. There are some religious affiliations that don't believe in blood products, so we have to make sure that we have consent before we give blood. So some of the nursing management for blood would be to follow your agency policy. We would need a prescribing order, which would include the amount of blood to be administered plus the type of product. So whether it would be a packed red blood cell or whether it would be a platelet transfusion. The lab would draw blood for a cross-match, and that's to make sure that the antibodies in the patient match the antibodies that are in the blood that the person is going to get. We would also need to make sure we have that written consent, and each agency would have the rule around who can sign the consent and those types of things. And then there is a few verifications to make sure that we have the right product. And so when the person, the nurse, goes to the lab to pick up the blood, the lab staff and the nurse have to check the blood product, reading the cross match to the unit to make sure that they're matching. And then again on the floor before the bag is spiked, that two nurses would be checking the identification of the patient as well as the identification of the unit to make sure that there is a match. We need to have baseline vital signs, and that is done originally at the start and then throughout the transfusion. And this is a picture I cut right out of our policy at Alberta Health Services as to how often and what you need to do when you're first administering blood. In the case of an adult, we have a set of vital signs to start, and then we stay at the patient's bedside with the patient for that first 5 minutes without taking our eyes off of them. So we have to converse with them. We don't go to our computer. We stay completely with them. And then for the next 10 minutes, we can look at our computer but we do want to stay with that person. And then after 15 minutes, we do another set of vital signs, and then every hour after that until the transfusion is complete. Blood products generally need to be administered within a 4-hour window from the time they're taken out of the fridge in the lab until it's completely finished. So a unit of blood contains somewhere between 300 and 500 mils. We would start the infusion slowly and run it over, say, 50 mils an hour to start, and increase it so that we can have that full unit into the patient before that 4 hours is up. Again, the rate would be a nursing responsibility depending on our patient. Can they tolerate a infusion rate that's higher? Are they having no problems? Those types of things. We would really individualize our assessment. And then we would always use an administration pump and the tubing. It comes with, blood product has a specific line with a filter that we need to run, and it can only be run with normal saline. And we would make sure that we have a designated IV for blood. We wouldn't run any other medications into that line. So if the patient was still needing IV medications and they were getting a blood transfusion, they would need to have 2 lines in place. And then, of course, the documentation is a big piece. So things that we would watch for is any type of an infusion reaction. And if we do see an infusion reaction, which would be an elevated temp or shivering or any signs of anaphylaxis, we would immediately stop the infusion. We would maintain the IV access using a new IV line and new IV fluid, because we will need that line, or possibly need that line. We will monitor their vital signs closely. We will notify the physician or the prescriber, and we will notify the transfusion lab, the lab in our case, as to where the blood transfusion came out of, or the blood product came out of. We would make sure that they know that there's been a reaction. So what do we do as nurses while we're monitoring our patient as they are getting fluids? We need to monitor their in and out, and we would be watching their urine-specific gravity. So that means that if they have a specific gravity greater than 1.025, it would mean that the urine is concentrated, and if it was less than 1.01, then it would mean that the urine is dilute. So we would be watching for signs and symptoms of cellular fluid volume excess. So we would see changes in that blood pressure. If there is a volume excess, we would see an increase in their pulse force. We would see increase in that jugular vein distension. We would watch them closely for respiratory changes. Again, if it's a fluid excess, we might hear some crackles or some noises in the lungs indicating that we've got some fluid in the lungs. We would want to monitor their weights daily. We would do skin assessments to watch for dehydration or edema, and we would do neurological assessments. So here's a picture of how to assess the skin. When you're assessing hydration status on a patient, we want to use the skin on the abdomen or the sternum or the forearm because the hands can be dehydrated.